Sorry, can we start now or?
We'll start. We're just waiting for people to come in.
For sure.
Okay, I think it's time to start. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening. Thanks everyone who joined us, and inshallah, hopefully more will join. Today is the theme for the Young Leader Forum is adrenal disorders, and we have three excellent speakers. As usual, we extend our great gratitude and thanks to Servier, who are supporting this educational activity. And this webinar will be live streamed in the Emirates Diabetes Endocrine Society YouTube channel. Also, you can view it later on demand webinar that will be available on the on-demand sections on the EDS Institute websites. I encourage all of you to post your questions in the Q&A section so we can address it later after the first three lectures. I will be moderating hopefully this session, inshallah. I'm Dr. Raya Al-Mazrou'i and I'm consultant endocrinologist at Tawam Hospital. Without further ado, I will introduce the first speaker, who is Dr. Ishma Ijazi. And Dr. Ishma Ijazi hold FRCP and MRCP from UK, as well as subspecialty in endocrine and diabetes, as well as postgraduate certificates in diabetes from Cardiff University. She is currently working as a consultant in internal medicine in Dubai Hospital, and she is a member of Emirates Medical Association, as well as Emirates Diabetes Society. She will give a lecture around the scheme to taper corticosteroids safely in non-adrenal disorders, which is a very common scenario that is encountered almost by all subspecialties. Thank you, Dr. Ishma, and the floor is yours.
Thank you very much, Doctor.
You just start sharing your presentation.
Yeah, sure, Doctor. Just a minute, please.
Sure.
Yeah. Can you see my presentation?
Yes, we can do. Just excellent. Now it's in presentation mode.
Okay, perfect. Okay. First of all, thank you everybody for joining us today after a busy working day. And I hope this presentation will be beneficial for all those who are listening, right? I'm Dr. Ishma, consultant internal medicine from the Dubai Hospital. And today we'll be discussing tapering of steroids in non-adrenal disorders. As a medical doctor, we see that we have a lot of patients and who are on steroids for a number of reasons, right? So the tapering of these steroids is an art as well as a science. And today we'll briefly go over that how we should plan a steroid taper for these patients. So I think all of us know that glucocorticoids, they are very potent anti-inflammatory and immune modulating agents. And we know that 1 to 3% of the population is taking steroids, and it has long-term steroids. They have a lot of widespread side effects. And we also know that if we give glucocorticoids in supraphysiological doses, it can cause suppression of the hypothalamic pituitary axis, and its abrupt discontinuation can cause cortisol insufficiency, and it can even precipitate adrenal crisis. And again, we also know that there is a risk of reactivation of the original disease. This slide might seem a bit fuzzy to you, but we know that glucocorticoids, they have a widespread effect on different organs of the body. In the GI system, they can cause peptic ulcer, they can cause gastroesophageal reflux, they can cause fatty liver, pancreatitis. The endocrine, we know they can cause a suppression of the hypothalamic pituitary axis. They can cause growth retardation. They can cause menstrual disturbances. And again, if you look at cardiometabolic effects, they can cause weight gain, they can cause insulin resistance, they can lead to hyperglycemia, dyslipidemia, and acceleration of the atherosclerotic process. And similarly, we see that they affect the musculoskeletal system, they affect the neurophysiological system, they can cause various dermatological issues, and they're also used as immune modulating agents. Just to briefly go over, we know that there are many different kinds of steroids. We have oral glucocorticoids, we have the injectable ones, we have the inhaled ones, which we're giving to COPD asthma patients. We have the topical ones, which are used for numerous dermatological issues. And we know that all these steroids, once you give exogenous steroids to your patients, they will cause a negative effect on the hypothalamic pituitary axis. And we know that they will cause depression of the corticotrophin releasing hormone, and this will cause a depression of ACTH, and again, the cortisol secretion will be depressed. So we all know that if you expose our patients to long-term corticosteroids, especially high doses, they will cause atrophy of the pituitary adenocorticotropes as well as the adrenal cortical cells. And we know that this will lead to tertiary adrenal insufficiency. Now, I think all of us as an internist and as an endocrinologist, and all of us in other specialities of medicine, have been encountering about tapering glucocorticoids. So, when we are tapering glucocorticoids, I think the most important thing is that we should remember two things. Number one, that the tapering should be gradual, so it should allow recovery of the hypothalamic pituitary axis, and also the risk of disease reactivation should be minimized. And also, the chances of having adrenal insufficiency should be minimized. We know that prolonged exposure to steroids and it causes atrophy of the corticotropes in the pituitary as well as the adrenal cortical cells, and this causes tertiary adrenal insufficiency. So again, we need to decide that in which patients we should taper steroids slowly and in which patients we should taper steroids fast. So, gradual tapering of steroids is required in those patients who are taking prednisolone more than 40 milligram daily and for more than 1 week, and also those who's been given an evening dose of steroids, those who have received more than 3 weeks of steroids, and those who are taking repeated courses of steroids after stopping those steroids. For example, we have COPD patients who come with acute exasperations, and we are giving them multiple doses, high dose steroids for short term.
Sorry for
And
interrupting, Dr. Ishma. Can you remove the message in the bottom of the screen?
sure,
Just
as
hide
well.
it. Yes,
Yeah.
please. Thank you.
All right. Okay. So again, we see that patients in which we can taper steroids faster. Yeah. So these are those patients, number one, again, the same thing, that the disease should not relapse and they should have received steroids for less than 3 weeks duration. Okay. And once we taper the steroids abruptly down to physiological doses, which is prednisolone 7.5 milligram, we have to reduce the steroids more slowly. And at the same time, we have to assess for the relapse of primary disease. If there is no relapse, we can continue our taper, but if there is relapse, then we have to go back to our original doses of steroids. So, we know that what are the risk factors for a hypothalamic pituitary axis suppression? It depends upon the potency and dose of the steroids, the route and the timing of administration, and also upon the duration of treatment. This is, we know, a calculation that 5 milligrams of prednisolone is equal to 4 milligrams of methylprednisolone, and this is equal to 20 milligrams of hydrocortisone and zero point 0.5 milligrams of dexamethasone. And I think this is a small table to tell us that what do we say that patients are on low dose steroids? Those who are taking less than 7.5 milligrams of prednisolone per day. Medium dose is those who are taking between 7.5 to 30 milligrams per day. High dose is those who are taking more than 30 milligrams but less than 100 milligrams per day. Very high dose take more than 100 milligrams per day. And again, pulse is those who are taking 250 milligrams of prednisolone equivalent per day. Again, we know that we have three ways of tapering steroids. Number one is a rapid taper, then we have gradual taper, and then we have slow tapering of steroids. So, if your patient is taking glucocorticoids more than 20 milligrams per day, say I've chosen the dose between 20 to 40 milligrams per day, because this is the usual dose which are given to most of our medical patients. So, what we do is that this dose should be reduced roughly by 5 to 10 milligram at 2 weekly intervals, or roughly 30 to 50%, till we reach a dose of 20 milligram per day. So once you reach 20 milligram, again, we follow the same rule. This is what I'm doing in my clinical practice, that we will taper 5 milligram every 2 weeks till we get down to a dose of 10 milligram per day. And again, if you're taking long acting steroids like dexamethasone, it is preferable to switch them to a shorter acting steroids like prednisolone. And at the same time, don't forget that we need to monitor, again, the flare up of the primary disease process. So once you've rapidly tapered off your patient's steroid and you reach a dose of 10 milligram per day, again, your tapering should become gradual now. And so you can go for a decrement of 5 milligram per day every 2 weeks, till again your dose reaches to 5 milligram per day. And again, you have to monitor the symptoms of a glucocorticoid withdrawal syndrome. And if you feel that these patients have glucocorticoid withdrawal syndromes, you have to slow down your taper process. Here, the whole idea is that once the steroids have gone to 5 milligram per day of prednisolone, which is the physiological dose of steroids, you have to allow for recovery of the hypothalamic pituitary axis to prevent cortisol insufficiency. So now your taper will be very slow. So what we're doing is that either we are tapering 2.5 milligrams every 2 to 4 weeks, or I think the better practice which we're doing in our medical wards is that we are switching the patients to hydrocortisone. The rough equivalent will be about 20 milligrams of hydrocortisone, and we can divide it between 2 to 3 doses. And then again, once you're dividing your hydrocortisone between 2 to 3 doses, you can again taper down by 2.5 milligram every 2 weeks to a dose of 10 milligram. So once you reach 10 milligram, again you would taper it down by 2.5 milligram every 2 weeks till you reach the dose of 5 milligram. So here you monitor your patients for effects of adrenal insufficiency, and if there are no signs and symptoms of adrenal insufficiency, you will continue your slow tapering dose. And at the same time, you have to educate your patients about uh, stress dose of steroids. Okay. Now, if your patients remain asymptomatic at the end of slow tapering, I think that's well and good. You can taper and stop your steroids. But at some time, for example, if your patients are taking a prolonged course of steroids, you might need to test the hypothalamic pituitary axis before you taper the steroids. And I think all of us know that we can do a baseline serum cortisol and we can do an ACTH simulation test. And both of them will decide whether we can taper our steroids safely or not. Okay. So, if suppose if the cortisol response to ACTH stimulation is normal, you can discontinue your glucocorticoids. But again, if it is not normal, then you have to reassess your patients after 3 to 6 months, and maybe do a test for hypothalamic pituitary axis stimulation after 3 to 6 months. I think usually in most steroid tapers, we're not testing the hypothalamic pituitary axis. So usually if you're taking steroids less than 3 months, we don't need to assess for hypothalamic pituitary axis. But again, if you're taking steroids for more than 3 months, and you have done a rapid tapering dose of your steroids, and you have come to physiological level of steroids, which is prednisolone 5 milligram per day. So before you're discontinuing or you're tapering your steroids from prednisolone 5 milligram per day, we can check the hypothalamic pituitary axis. So again, I think this is simple, which we're doing in clinical practice all the time, that we are sending a dynamic cortisol level, which is an AM cortisol level. And if the AM cortisol is less than 100 nanomole, we are diagnosing adrenal insufficiency. And again, if it's between 100 to 450 nanomole per liter, it is inconclusive and we need further dynamic testing for our patients. And we know that the dynamic testing is the synactin test, which again, all of us know that we're giving 250 micrograms of synthetic ACTH synactin, either IM or IV, and we check the ACTH, the cortisol level at 30 and 60 minutes interval. And again, we know that if your cortisol values above less than 550, it's diagnostic of adrenal insufficiency. Similarly, we can use the low dose ACTH, which is 1 microgram simulation test in people with secondary and tertiary adrenal insufficiency. Although we have a meta analysis showing that the sensitivity is the same for both the tests in secondary adrenal insufficiency. I think all of us know that prior to this, the short synactin test, hydrocortisone needs to be stopped for 24 hours, and prednisolone we need to stop for at least 48 to 72 hours. And again, if your results are subnormal, we need to assess, we need to continue these patients on the same dose of glucocorticoid replacement therapy, and we should reassess our patients after another 3 to 6 months. So here I've just tabulated. So here I've just tabulated. Um, we have high risk patients are those who are taking prednisolone greater than 5 milligram for over 4 weeks. Moderate risk are those who are taking prednisolone greater than 5 milligram for 2 to 4 weeks, and low risk are those which are taking any dose less than 2 weeks. So those who are taking a dose which is greater than 4 weeks, they are at a greater risk, or they're at the highest risk of glucocorticoid-induced adrenal insufficiency, as compared to people who are taking steroids for 2 to 4 weeks or less than 2 weeks. And again, we know that because in our COPD patients, um, we are giving short bursts of steroids. So as a result of this, 10 to 15% of these patients can develop adrenal insufficiency. So again, I agree that abruptly stopping steroids can feel like slamming on the brake, and it's okay to wean rapidly from very high doses, but around prednisolone 20 milligram, we need a slow taper. So here we know that when you have patients and you're tapering steroids, you have to look for signs of adrenal insufficiency. And we know that glucocorticoid induced adrenal insufficiency can be either asymptomatic, it can either precipitate an adrenal crisis, or they can be symptoms can be very mild. So again, we know that it is less dramatic in presentation as compared to a primary adrenal insufficiency. And again, the diagnosis is supported by low baseline or stimulated cortisol levels. And the only thing is that we don't have any guidelines by the Endocrine Society for the management of specific glucocorticoid induced adrenal insufficiency. So, again, if patients are symptomatic, you have to treat them with physiological replacement doses, and we don't require mineralocorticoid replacement, especially in those people who have tertiary adrenal insufficiency. And you have to counsel your patients about stress doses in times of surgery, in times of any illness. And I think this is the most safest approach. Now, if you look at the physiological replacement of glucocorticoids, uh, one of the major aim of tapering down glucocorticoids is we want the recovery of the hypothalamic pituitary axis without precipitating signs of adrenal insufficiency. So this is basically done by maintaining the patients on a physiological dose of glucocorticoids, which are not suppressing the hypothalamic pituitary axis till your endogenous cortisol production is resuming. So again, that means that your physiological replacement, it should mimic your normal cortisol production and also your circadian rhythm. So here, I think all of us know that if we look at our graph here, we know that your maximal cortisol surge occurs in early hours of the morning by 6 a.m., then this would probably plateau down to 50% by lunchtime or in the afternoon, and then later it will plateau down in night. So, what's happening here is that uh, the ACTH secretion also occurs in the early hours of the morning to cause the early surge of cortisol. So when you're replacing physiological replacement doses, so it's very important that your short acting or intermediate acting glucocorticoids should be given in the morning. So this will allow a late nocturnal ACTH surge and which will cause a recovery of the hypothalamic pituitary axis. So I think let's consider this example that if your patient is on hydrocortisone 10 to 15 milligrams, so they should basically given be 2 or 3 divided doses, and the largest dose should be given early morning, and smaller dose should be given in the afternoon and evening. Uh, and if your patient is on prednisolone, you should give the prednisolone 2.5 to 5 milligrams in the morning. Definitely, switching to hydrocortisone allows faster recovery of the hypothalamic pituitary axis, but we do not have any head to head trials. And again, we cannot use dexamethasone or we cannot use betamethasone. And once you've brought your patients, you've tapered down the steroids to a physiological dose, you have to counsel your patients about stress dose of steroids in times of acute medical or surgical illnesses, and also in terms of if you want to prevent adrenal crisis, at times the steroid dose can be increased to 2 to 3 times. And again, if your patient comes with vomiting, unconsciousness, illness, or major surgery, hydrocortisone can be given. So, as we already discussed, that if you're giving long-term steroids therapy, you can have a tertiary adrenal insufficiency. And we know that Borstron et al. Reported that 15% of those patients who are on long-term steroids, they can have a persistent adrenal insufficiency for 3 years or more. So again, as I said, that glucocorticoid tapering is an art on the background of a science. And I think the most important formula we should know that a general rule is that recovery of adrenal function takes approximately 1 month for every 1 month of hypothalamic pituitary axis suppression. So, for example, that if I'm giving glucocorticoids to my patient for over 1 year, so when I stop it, I should know that it will take at least 9 to 12 months or even longer for the recovery of the endogenous cortisol secretion. So again, in these patients, we should continue do dynamic testing of the hypothalamic pituitary axis before discontinuing the steroids. And if the dynamic testing there is subnormal levels of endogenous cortisol, we will continue them on physiological doses and repeat the dynamic testing after 6 to 12 months. Again, I think here all of us should know about glucocorticoid withdrawal syndrome. We know that once you're tapering glucocorticoids, people can develop non-specific symptoms like headache, fatigue, fever, low blood pressure, vomiting, nausea, joint pains, and muscle pains. So this is a syndrome which was described in 1960, and especially these patients, it appears they may appear in patients who are above the physiological replacement dose of glucocorticoids. And again, we don't know the exact etiology, but it can be due to a state of relative glucocorticoid receptor resistance, which is resulting in physical dependence on supraphysiological cortisol level. And again, we know the mechanism is that if you give prolonged steroids to people, it causes downregulation of certain mediators, and it causes upregulation of cytokines and prostaglandins. But as a clinician, the most important thing is that we have to differentiate this from a tertiary adrenal insufficiency. And we know that the management of glucocorticoid withdrawal syndrome is a temporary, modest increase in glucocorticoid doses, and we have to give them the lowest doses in which the symptoms improve. And usually it's self limiting within 6 to 10 months. And we have supporting care like adequate diet, physical activity, NSAIDs, and mild antidepressants. And patients should be counseled about the temporary nature. So, just a rough comparison, the adrenal insufficiency and glucocorticoid withdrawal syndrome, we know that when you taper steroids, again, the symptomology can be the same, and sometimes it is very difficult to differentiate. But again, if you check the hypothalamic pituitary axis in adrenal insufficiency, your basal cortisol and your after ACTH stimulation, it will be low. But here in glucocorticoid withdrawal syndrome, the tests of hypothalamic pituitary adrenal axis will be normal. The risk of adrenal crisis is there in adrenal insufficiency, but we do not see in glucocorticoid withdrawal syndrome. And again, in adrenal insufficiency, you have to continue your patients on physiological doses of steroids. But in glucocorticoid withdrawal syndrome, you can even continue, you have to maintain your patients on the lowest possible glucocorticoid dose, which does not give rise to withdrawal symptoms. And at times, this can be above the physiological dose. Again, in adrenal insufficiency, you have to counsel your patients about a stress dose of glucocorticoids during any illness, but in glucocorticoid withdrawal syndrome, uh, there is nothing like this. Again, just to summarize in a nutshell, if you're on low dose steroids less than 3 weeks, you don't taper. If you're taking a dose between 50 to 20 milligrams and you're taking them more than 3 weeks, you need to taper these patients, okay? And again, if you're taking these steroids for more than 3 months, then again, you might need to do tests for hypothalamic pituitary axis before you decide to taper and completely stop the steroids once your patients are reaching to the physiological dose of steroids. This is, I just put in a small table here that if you're taking more than 40 milligrams of prednisolone per day, okay, and then, if you're taking them for more than 3 weeks, then your taper should be uh, approximately 10 milligrams per week, and this should be in 1 to 2 weeks. And then if you're taking between 20 to 40 milligram, it should be maybe 5 milligrams weekly. If you're taking between 10 to 20 milligram, it should be 2.5 milligram, say every 2 weeks. And again, if you've reached a level below 10 milligram, then you should do a very slow tapering, 1 milligram every 2 weeks. And once you reach the physiological dose of less than 5 milligram per day, your tapering should be very, very slow, maybe zero point 0.5 milligram every 2 weeks to allow recovery of the hypothalamic pituitary axis. So, just to summarize that glucocorticoid tapering, it's an art in the background of a science. And the main aim of your tapering is to allow recovery of your hypothalamic pituitary axis without affecting the primary disease. And it is a teamwork and involves a close liaison between the primary physician, the endocrinologist, and the patient. And the plan of taper again should be individualized. There is no hard and fast rule. Thank you.
Thank you so much, Dr. Ishmat.
You're welcome.
Thank you for the details presentation. I just would like to highlight that there was a joint, maybe I misunderstood, but there was a joint guideline regarding steroid-induced adrenal insufficiency diagnosis and the treatment. That is a joint guideline between Endocrine Society and European Society of Endocrinology that was released last year. Excellent. So without further ado, we'll move to the next talk by Dr. Faryal Ashfaq. And Dr. Faryal, if you is will is a is she completed her Arab board and MRCP and a specialty certificate in endocrinology and diabetes, and she's a specialist registrar in Dubai Hospital as well, and she's member of the Royal College of Physicians. Dr. Faryal will present an interesting case that is a complex around pheochromocytoma crisis. Welcome, Dr. Faryal, and the floor is yours.
Hi, good evening, Dr. Aya. Thank you so much. Thank you for the invitation as well.
Thank you.
I'll start sharing my presentation. Bismillahirrahmanirrahim. Today I'm going to discuss an interesting case of paraganglioma and pheochromocytoma in pregnancy that we had encountered in our department in endocrine, the hospital. This is a very challenging case. We will be discussing the main challenges we faced during the management of this particular case. So let's start with the case. Bismillah, these are the agenda overview for today's presentation. I'll be starting with the case discussion, then we will move towards the understanding of PPGL, which is pheochromocytoma and paragangliomas, incidence in the pregnancy, impacts on the pregnancy regarding these particular type of tumors, what are the different diagnostic and monitoring approaches in pregnancy, treatment options, pre-op and post-op care, and post-op postpartum follow-up. So let's start with the case. We had a 39-year-old female. She's gravid to para 1. She presented in Latifa Hospital with a complaint of palpitations, sweating starting from 20 weeks of gestation. She had episodes of high blood pressure followed by low blood pressure readings along with the palpitations, and each episode was lasting around 3 to 5 minutes in total duration. She was a known case of hypertension from before since 2016, and patient presented to us late 2023. Based on the high blood pressure readings and initial workup showing significant proteinuria, she was started on labetalol and magnesium sulfate with the presenting diagnosis of preeclampsia. Going further into her past medical history, she was known to be diabetic since 2016, non-case of hypertension since 2016, having medications, and obesity with BMI of around 32 to 33. Her past surgical history was significant with the previous C-section and myomectomy for endometrial fibroids in 2015 and 2021. Her medication history included the use of insulin and metformin for the control of her diabetes during pregnancy. Before pregnancy, she was mainly on metformin. So her baseline glycemic control was not very bad. Family history was positive for hypertension in her mother and colon cancer in her father due to underlying familial adenomatous syndromes, but there was no family history of any adrenal tumor. On physical examination, she had vital signs of blood pressure of 144/76 on initial presentation, with heart rate of 89 beats per minute and respiratory rate was 16. She was afebrile, and she had a gravid uterus of 28 weeks. And on lower limb examination, she had no lower limb edema. These are her baseline blood investigations, which were done in Latifa Hospital. She had a complete WBC, full blood count showed a WBC count of a slightly upper limit, normal 12.8. Hemoglobin was 10.1 with slight increase in the platelet count, but still normal with no tendency of bleeding during her hospital stay. Liver function tests were documented as normal, negative cardiac markers, and pro-BNP was normal and normal kidney function tests. Because she was having complaints of recurrent episodes of high blood pressure followed by low blood pressure readings, hypotension, syncopal attacks, along with palpitations on the background history of hypertension. So she was referred to cardiology team and she was worked up for any underlying cardiac etiology which could present her symptoms. So her transthoracic echo result was non-specific. Only significant finding was she had an ejection fraction of 55 to 60%, which was quite acceptable. And she had severe concentric left ventricular hypertrophy, which was again going for her long-standing hypertension. Holter monitoring only showed the sinus tachycardia and few ventricular and supraventricular ectopic beats, but there were no patient-triggered events were documented in that. Because she had repeated episodes of hypertension with hypotension, so the initial suspicion of working into lines of pheochromocytoma was entertained, and the first workup was sent regarding plasma metanephrines. If we see in the screen, the highlighted ones, we had a very high metanephrine level, which is more than 10 to 15 times upper limit normal. The lower, the reference weight was less than 120 nanogram per liter, and the result in her case was more than 2,000. In view of probable diagnosis of pheochromocytoma or noradrenaline secreting tumor, she was shifted to the Dubai hospital for further management. Her other lab parameters was plasma catecholamines level. We all know that catecholamines level are the original chemicals or the sympathetic nervous system hormones, which are later degraded into metanephrine. So she was evaluated in both ways with catecholamines as well as metanephrines. If we see her noradrenal level was also more than 2000, which is again more than 5 times upper limit normal. Her urinary metanephrine analysis showed 5,580 microgram per gram creatinine, which was again more than 10 times upper limit normal. Here we are dealing with a young lady who is pregnant around 23 weeks, and her biochemical profile is suggesting that she's having noradrenaline or norepinephrine secreting tumor. So MRI abdomen was ordered to localize this catecholamine secreting lesion because she was pregnant and risk of the contrast for the fetus was there. So it was without contrast MRI. It was a plain MRI. We can all see in the picture attached for the image that she had a very well-defined lobulated retroperitoneal soft tissue mass was there of around size 5 into 5 into 5 centimeter, and it was abutting the inferior vena cava and the posterior wall of the gravid uterus. If you can see in the picture on the right side, I have marked it with the red arrow. This is the big tumor which was localized in her imaging. So in the nutshell, we have a young lady who is having a noradrenaline secreting tumor and 23 weeks of gestation. So there were many questions to be answered at this point. How to manage this lady preoperatively, what are the specialties need to be on board for the smooth delivery and for the proper care of the patient in the pre-op and intra-op period and or in the perinatal period. So we had conducted a multidisciplinary team meetings for this particular patient where we had involved endocrinology team, urology team in view of an adrenal lesion, gynecology and obstetrics, because we had two lives taking care on board at the same time, one fetus and one mother, neonatologist in case of any neonatal or fetal emergency we are expecting after the delivery, and anesthetist to work on the choice of the drugs which we need to be taken care during the peri-op or peri-delivery period. So what was the MDT plan in this particular patient? Because patient was still in 23 weeks gestation, 23 plus 3, which is before the age of fetal viability, which is considered at 24 weeks usually, documented in the literature as well, 24 weeks at the fetal viability age. So the plan was to continue fetal observation with the weekly scans from the obstetrician and to look at the fetal maturity, lung maturation preparation, to give her steroids for the lung maturation, and to plan an elective C-section at 30 to 34 weeks of gestation. So here we are talking about a patient who is still 10 weeks before the delivery, at least 10 weeks. We have to give her a margin. She's 23 plus 3 now, and with a very critical, highly noradrenaline secreting tumor we had. We had discussed the anesthesia plan, which anesthesia should be better for this patient, what should be done in the postpartum era or in the postpartum time to facilitate the diagnosis and definitive plan for this paraganglioma or tumor, and what should be the appropriate timing for the surgery for this pheochromocytoma or PPGL. Okay, so here I finished the discussion regarding this particular case. At the end of presentation, we will go back to the case and we will see what was the outcome of the pregnancy, how the patient was managed in the perinatal period and antenatal period. So far I have used the term PPGL in multiple slides. It is very confusing for most of us, even for me at times it's very confusing. So let's do a breakdown of this particular term of PPGL. So the word PPGL actually the first P stands for pheochromocytoma and the next PGL stands for paraganglioma. So why this is a collective term, why we use it as a PPGL mnemonic when we are confused from the origin of the cells. If you look in the current slide, on the left side, we have neural crest cells. These are during the time of embryogenesis, we have these neural crest cells, which are migrating into different parts of the body to have their own location. In the second half of the slide, there are chromaffin cells and neuroblast cells. Actually, neuroblast cells are the cells which are taking place around our vertebral canals to make the sympathetic ganglia or the sympathetic nervous system chain, we call it. So any tumor of these neuroblast cells, we call it neuroblastoma. My main focus here is regarding chromaffin cells. Now, this specific subcategory of neural crest cells, they are destined to be located either in the adrenal gland, specifically medulla, or next to the sympathetic ganglia. So if these cells are locating in the adrenal medulla, and the tumor of these will be causing pheochromocytoma. And if they're locating in next to sympathetic chain, that is the paraganglioma. In this slide, I have done it's an interchangeability term between pheo and paraganglioma. These chromaffin cells, if they develop a tumor within the medulla of adrenal gland, they are pheochromocytoma. And if they are developing a tumor next to the sympathetic chain, they are called paragangliomas, or in other words, we can say it's a pheo, but it's outside the adrenal, or extraadrenal pheochromocytoma. So it's more or less the interchangeably term. The PPGL stands for, first P is for pheo, and the PGLs is paragangliomas. Why they are grouped together? Because origin of the cells is chromaffin cells. So we are talking from specific neurocrest cells, which are destined to be in our body at different parts and have different roles in the functions, and their malignancies have different susceptibility to different type of tumors and release of the hormones. In our case, what is special? We all know about the pheochromocytoma crisis. We all know about paragangliomas. How do they present? In our case, we had two lives on stake, or two lives to be taken care. One was mother and the other was fetus. So first of all, this condition is very, very rare. So you can see the references down. It's 0.007% in all the pregnancies. Another author in the recent publication in 2022 by Dr. Mahajna, he has mentioned it has a very scarce prevalence of 1 into 50,000 pregnancies. So I would say that our patient fell into that particular category, which if we had 54,000 pregnancies, she's one of that lady who can have PPGLs in pregnancy. The scary part about having a PPGL in pregnancy that it can easily be misdiagnosed with preeclampsia, because presentation could be pretty much same, and the mortality is very high as 15% if it's not detected at the right time and not treated very well. In all these patients who have PPGL, pheo, and paragangliomas, in 40 to 60% of the cases in most of the literature, there are associated germline baseline mutations are there. However, there could be sporadic variants. And 30% of the patients, if 30% of the patients with PPGL in pregnancy, they are not diagnosed until postpartum. And the situation is much, much more difficult in the postpartum period, because it always comes as crisis post-delivery period. We all know that what is the most likely presentation of pregnancy of PPGLs in normal persons without pregnancy. Usually it's a triad of hypertension, palpitations, and intermittent episodes of sweatings, feeling of fear. This is the usual presentation, but the triad is not present all the times. It's one or two symptoms come in succession. We don't see that all the patients have fulfilling the triad. If it happens, then the clinical scenario must be very, very easy to pick up and to proceed with investigations. But the medicine is not that easy all the time. So we don't get all the symptoms at the same time, or patients did not fit into the usual triad. So the presentation is a bit more critical in pregnancy. 77% of the patient can present with hypertension only. 58% of the patient can have palpitations, which can again be misread as initial presentation of pregnancy, first trimester sickness, or headaches because of low volume. At the same time, 45% of the patient can have an independent complaint of sweating only as a presenting complaint. So you see from this pie chart that picking up or presenting with the one symptom can be very critical to pick up the diagnosis in the beginning. In this particular literature review from William Young, he has mentioned that only 5 to 10% of the patients are diagnosed antepartum, because the condition is being overlapped with many other symptoms of pregnancy, and it's overlooked, and patient can be missed very, very easily. So that's one of the purpose of today's presentation, to increase the awareness among the physicians, endocrinologists, and internists, to not to skip the major finding or even one presentation in that particular lady. We all think, or even before presenting at this forum or before going into details of this topic, my general impression was that if a patient has any tumor, noradrenaline or adrenaline secreting tumor, he or she should present. She should present in the third trimester because of obvious mechanical reasons, that the gravid uterus is enlarging. There is a mechanical pressure on the tumor itself, which can cause release of the hormone and can give the presenting symptoms. But what happened if the patient presents in the first trimester with these symptoms and diagnosed in the first trimester? So there have been many studies done. If you look into this beautiful picture by Dr. Lopez AG, there are multiple studies and experiments have been done that specifically pheochromocytomas, if they are there in the body before the pregnancy and the pregnancy happens, these particular cells, they express a lot of receptors to luteinizing hormone and HCG hormones. We all know that the first trimester is the time where we have the highest concentration of beta HCG. So if some cells are overexpressing the receptors for this particular hormone, it induces the production of epinephrine and norepinephrine from these silent tumors which were there before pregnancy, and patient can land up into pheochromocytoma crisis. So in most of the patients, when it is not recognized because the picture is having overlapping picture with other symptoms, it can again go into silent pheochromocytoma in the postpartum period. Patient might be very, very lucky if they don't diagnose during antepartum and during their pregnancy. They go unnoticed without any complication. They can go into silent pheos after the delivery as well. This is because of the excessive expression of these receptors. So as I said, the first and foremost differential for PPGLs is the preeclampsia. So this is a beautiful literature review from Dr. Olivia. She has documented multiple differentiating points between PPGLs and preeclampsia. So first of all, if we look into the table, the first feature is the timing of the presentation. PPGL can present at any time of the pregnancy, be it first, second, or third trimester, based on the theory which I have just explained. But the preeclampsia usually comes after 20 weeks of gestation because that is the time period where it comes the pregnancy-induced hypertension and consequences of the features which would happen. In hypertension usually is very paroxysmal in PPGLs. It is more common to have orthostatic hypotension in PPGLs in comparison to preeclampsia. Headache can be very severe in preeclampsia, but could be mild to moderate in PPGLs. Flushing and palpitations and episodic nature of the symptoms is more in paragangliomas rather than preeclampsia. And it's very less likely to have a pedal edema in paragangliomas rather than preeclampsia. If you remember, our patient had no pedal edema. There was a reason to mention this finding, and we had gone back and looked into it exactly. Patient never had pedal edema in our case. So that was another finding, goes more in favor of PPGL rather than preeclampsia. Moreover, our patient was non-diabetic from before, but still, because there is increased level of epinephrine and norepinephrine, and these are stress hormones, it's one of the body's sympathetic response system. So we do expect to have high glucose levels. So her glucose level became a bit abnormal during her pregnancy. She had normal liver enzymes. She had no thrombocytopenia, which is a hallmark of preeclampsia as well, and she had elevated catecholamine levels. So what are the risks for maternal health? Patient can be at risk of hypertensive crisis, which can be organ dysfunction, hemorrhage, acute myocardial infarction, stroke. They can have cardiac arrhythmias and neurological effects, and even the maternal death. We will talk about mortality in this particular group of patients at the end of our presentation. What could be the effects on fetal development? These catecholamines, they do not cross the placenta. So the effect of catecholamines on the fetus is not direct. Why baby's health or the fetus or in vitro fetus is compromised because of the sudden fluctuations in the hemodynamics. Becoming hypertensive followed by hypotension, it can affect the uteroplacental circulation and can result in the fetal hypoxia, intrauterine demise, and even after the birth, patient can have neonatal distress and death. So as the diagnosis is very challenging from the beginning for having two conditions at the same time, the question arises, should all the patients with pregnancy should be screened for PPGL? Because we said it's rare, but mortality is high. So the answer is we don't have any definitive guidelines for this particular area, but from Dr. William Young and Dr. Olivia, they have said that screening for all the patients is not recommended for all the chronic hypertensive patients, number one. Number two, if the patients have signs and symptoms suggestive of PPGL, patient has a definitive lesion on the imaging, obvious, or genetic predisposition with family history of paragangliomas, or first or second degree family member with paragangliomas should be screened for before the conception for the diagnosis of PPGL. We all know that there are significant diurnal variations in the hormones. There are significant hemodynamic changes, intravascular volume changes. So everything is upside down in pregnancy. So we really don't have standardized values for the diagnosis of PPGL in pregnancy. But as a general rule, if the metanephrines or normetanephrines are more than 2 times upper limit normal, provided there is no interfering drugs in the assay, it's a leading point for the further investigation. Coming to the imaging investigations, as we said that we are dealing with 2 lives and we cannot risk any of them. So ultrasound abdomen in the first trimester can be helpful. For example, if it's a really big mass and can be seen when the fetus is small before 24 weeks of gestation, we can suspect a PPGL in the retroperitoneal space. Or we can do MRI without gadolinium contrast like we did in our patient. But we cannot do CT scan with contrast, any functional imaging or PET scan because it can be harmful for the patients. So this is now we are coming to the main point of the treatment, where is the treatment protocols for the patients who are having PPGLs. So basically we have to take care of close monitoring for the patient as well as for the fetus. So here comes the role of multidisciplinary approach. For this patient, literally, I would say the OB/GYN team was on board for every day follow-up on the patients and weekly scans for the patient, looking for amniotic fluid, fetal heartbeat, and everything was of utmost importance at that time. So from the treatment point of view, we have medical treatment, surgical options, and then we have postpartum follow-up care and genetic screening. Most important thing at our level or as an endocrinologist level is the optimization of the patient preoperatively or in the peri-delivery period. So as soon as the diagnosis of PPGL or pheochromocytoma is made, patient needs to be started on alpha blockers, followed by 1 week delay that we are sure that all the alpha receptors have been blocked. We will start with beta blockers, and if patient has persistent hypertension or resistant hypertension, there is a role of introduction of calcium channel blockers after 2 to 3 weeks. In the next 3 slides, it feels a bit messy, the slides, because these are the dosing. I don't want all of us to memorize it by heart because I just want the audience to get an idea that there are a number of medications available which can help us in optimization of the patient before the surgery. So the first slide is about alpha blockers, where we have phenoxybenzamine, prazosin, and doxazosin. Phenoxybenzamine is a non-selective alpha blocker, and it's widely available, but it has a high risk of post-operative hypotension, and it depends on the availability of the drug as well. In our patient, we use prazosin for the alpha blockade. So the starting dose is 1 milligram per day and optimization by 1 milligram every day to reach the target blood pressure and the target heart rate, which I will be discussing soon. In the second slide, we have for beta blockers, propranolol, atenolol are not recommended. They are not a standard recommendation for the use. Metoprolol starting dose is 25 milligram, but again, the risk of bradycardia, orthostatic hypotension, and dizziness is there. And esmolol is kept only for emergency use. From calcium channel blockers, we have a number of them, starting with the nifedipine, amlodipine, and nicardipine. For nifedipine, the starting dose is 30 milligram, and most of them have the same area of side effects with edema, lower limb edema specifically, headache and dizziness and flushing. In our patient, we do not require to start or introduce the calcium channel blockers because she had a different hemodynamic profile to deal with from the beginning. So what are the surgical intervention and what's the timing? Well, this is a very controversial area. When the surgery should be done, how the surgery should be done, or what should be the mode of delivery. It depends if the pheochromocytoma is diagnosed before the 24 weeks of gestation or the fetal viability. Surgery can be done before the initiation of second trimester. But if somebody is diagnosed within the second trimester, surgery should be delayed till the delivery for the PPGL. And there are some concerns regarding excess catecholamine secretion. And if there is a prolonged duration of anesthesia agents, there is tumor manipulation during the surgery, which can cause excessive release of catecholamine and cause hemodynamic instability. But still, it's a case-to-case variation. Each patient, not all the patients fit in one size, not one shoe fits for everybody. So we have to have a case-based approach with the involvement of MDT. So here comes the pre-op and intra-op care, or the pre-delivery antenatal care for this. We need to have a detailed cardiac assessment, blood pressure, heart rate control, and hemodynamic instability. We have to be prepared for any hemodynamic instability, be it hypertensive or hypotensive crisis. Regarding the medications, if we want to avoid a post-operative hypotension, doxazosine needs to be stopped at least 12 hours before the surgery, and phenoxybenzamine at least 24 hours. To have a good intravascular volume, because patient is at high risk of postural hypotension with alpha blockers, a high sodium diet needs to be introduced in the pre-surgery period. Patient should be on continuous IV fluids, 1 to 2 liters of saline infusion before to the surgery. And we should be ready for any hypertensive crisis on table with phentolamine and sodium nitroprusside drugs. This is a pre-op and intra-op care algorithm. Actually, this is not for pregnant ladies. We do not have any standard or cutoff points in the guidelines for the blood pressure targets for PPGL in pregnancies. But in the normal individuals, in the non-pregnant ladies, this is the approach. That first is the addition of alpha blockers and high sodium diet to prevent postural hypotension. If we reach the blood pressure, very well and good, and we can add beta blockers for uncontrolled blood pressure or tachycardia. Then the preoperative goal is to maintain a seating blood pressure as 130/80, and the blood pressure should not drop more than 90 millimeter of mercury when the patient is standing. Ideal heart rate should be 60 to 70 beats per minute seated, and the patient is standing, it should be maximum 70 to 80. Remember that these are the targets in non-pregnant. In pregnant ladies, there is recommendation or a consensus on the slightly higher blood pressure of 140/90 because there is increased risk of uteroplacental circulation compromise. Now coming to the post-operative care, there are two major complications that we should be aware of in the post-op period. Number one is the post-operative hypotension, and there is a reason for it, why we have it, because patient is on high-dose medications, antihypertensive before surgery. There is a risk of surgical blood loss, which can cause contraction of intravascular volume and sudden fall in the circulatory catecholamines. So these are the main driving factors for the post-operative hypotension. If somebody is having very large tumor size, low body mass index, they are at increased risk of developing this particular complication. The other significant complication that we can expect in the post-op period during the ICU stay is the hypoglycemia. And why do we have it? Because we have a sudden drop in the hormones or catecholamines, which had initially caused an increase in the insulin release. So now we are expecting that side effect that catecholamine level is withdrawn and there is a sudden enhanced release on the insulin. So there can be increased risk of hypoglycemia. Usually it is seen 2 hours to 4.5 hours, and it's recommended to do post-op blood glucose profile every 4 to 6 hours. What is the post-surgical surveillance? It's all the patients needed to be followed up post-surgically, repeated biochemical profile in 2 to 6 weeks' time to make sure that the patient has achieved remission. And specifically in high-risk patients who had a tumor more than 5 centimeter or bilateral or young patients with genetic disease, they should have annual follow-up. And MRI needs to be done every 1 year for the first 5 years to reduce the radiation exposure and to have a follow-up. Now, because we have gone a lot in detail for paragangliomas and FUs, now coming back to our patient, actually this patient had a stay of around 70 to 80 days in hospital. Inpatient monitoring was done for the mother and the fetus. The main challenge was to control her blood pressure from the hypotension point of view, because if you remember, I had discussed in the beginning that she had severe hypotension requiring the assistance to have help to even to going to the toilet as well. She was requiring somebody to take her with her. So she was optimized with prazosin and bisoprolol. The fetal ultrasound was done every week to make sure that the fetus is doing fine. There is no drops in the circulation. And at 31 plus 4 weeks, she had episodes of labile hypertension. I will be showing the readings, what were the blood pressure readings before surgery and after surgery. and we had to convince her to take alpha blockers before the surgery for better optimization and better outcome. And she was on IV fluids continuously. At 32 weeks gestation, she underwent a C-section and the general anesthesia of a very short duration under the expert physicians and the gynecologist obstetricians to minimize the duration of surgery. And after that, patient was shifted to ICU. She was resumed on her post-op in her medications with alpha blockers and beta blocker. If you remember, we had decided initially to keep her till 34 weeks medical observation, but because she had a very labile blood pressure readings to an extent that her systolic blood pressure was dropping to 80s and she was not able to even lie down flat. We are not talking about somebody who is standing and dropping the blood pressure. She was lying down flat, turning to left side, and her blood pressure was dropping. So the product of her C-section, we had a delivered healthy baby girl of around 2 kg. It was in January 2024. And after that, she was discharged from the clinic and she had undergone a paraganglioma surgery in Cleveland, Abu Dhabi in April 2024. Unfortunately, we don't have the post-op histopathology report, but clinically we had a diagnosis of noradrenaline secreting paraganglioma. Post-delivery, the baby was kept in observation for 48 to 72 hours. Contraception was advised to her in case if she has further a plan to extend her family. Until the surgery is done, she was advised to have appropriate contraception, not to dip into the same situation again. And genetic testing was offered to her. We had drawn bloods for genetic testing, but all her genetic panel were negative for any genetic predisposition for these particular paragangliomas. And she was advised to do plasmapheresis and imaging before any next pregnancy. So here I finished the discussion of that particular case, her hospital course, and the product of the C-section. Now, why this case has been brought to this particular forum? We all know that hypertension is one of the main clinical features that can present as a crisis. So it's very easy to pick up or to guide towards the diagnosis. In our case, she was hypertensive before of around 8 years duration on medication, severe enough to call LVH, but she had severe spells of hypotension. So this was something which is usually not expected from a noradrenaline secreting tumor. It's a very varying kind of presentation from this particular tumor. We have always seen noradrenaline causing hypertensive crisis and difficult to control or resistant blood pressure, but here we had severe hypotension and difficult to manage her or optimize her. In the current slide, if we see that on the left side, we have pre-op readings.
We have 2 minutes left. We already
Yes, Dr. Raya, I'm finishing inshallah in 2 minutes. Okay, in the current slide, we can see that on the left-hand side, we have pre-operative readings on 9th of January 10 till 15, where her blood pressure was dropping to 105, 99 systolic, even going to 80s. And one day before the surgery, she had very high blood pressure readings because she was afraid to take the medications. Our target was to fully alpha blockade her, but she was not taking medications because she was severely symptomatic. In the post-op period, when she had removed the surgery has been done and baby has been delivered, her blood pressure shooted up again. So this is a varying presentation of having hypotension with concomitant pregnancy and going back to hypertensive crisis in the post-op and post-C-section period. During her discharge, on her discharge, she was very well controlled again on alpha and beta blockers till the surgery is planned, and her systolic blood pressure was ranging from 118 to 134 with a considerable and acceptable diastolic blood pressure as well. The main purpose of today's presentation is what improves the mortality in a patient who is pregnant and having PPGL. In the two studies I have quoted in 2022 and 2020, these are two main focus of presentation and references, and both have mentioned that decades ago, if we are talking about in the 80s and in 70s, the survival rate was only 50% here in the yellow block for the mother and the fetus both. But because of early recognition and appropriate periop care, this the death rate has decreased to 1% and even to less than 9% for the fetal loss. On the left-hand side, the same has been propagated by Dr. Mahanjana. He has mentioned that the mortality rate has decreased from 50% to less than 5% just because early antepartum diagnosis and appropriate alpha blockade. And here is the take-home message. It's rare but dangerous and fatal to both. Early recognition can improve the significant mortality, even without having the surgery. This percentage is without having the surgery, the mortality has improved. Clinical cues are very important and vital in the diagnosis, and multidisciplinary team meetings are very, very important in managing these particular patients. And thank you.
Thank you so much, Dr. Faryar, for sharing this very interesting and challenging case, and congratulations for your team for managing this complex case. It is
Thank you.
rarely
Thank
seen,
you so much, Dr.
and I think well done, well done. Excellent. So we'll move to the, without further ado, we'll move to the third talk, but I would like to remind our audience to place their question into the Q&A section. Even if you have some comments, please add it. We will just address it in the Q&A session. So the third topic will be given by Dr. Bakhit Bishtawi, who has been of a great support to us in the Young Leader Forum with his interesting lectures around the skills. He is the editorial and review administrator in the editorial office of Dubai Medical Journal. He's a specialist librarian and in Rashid Medical Library in the Medical and Education Research Department in Dubai Health Authority. He will give us a talk today about how to create and manage a Google Scholar academic profile. Welcome again, Dr. Bakhit, and the floor is yours.
Thank you very much, Dr. Raya. Let me try to prepare my slides. I start sharing, is it okay?
Yes, we can see your slides, sharing mode.
Okay, and what about the voice?
Yes, we can hear you well.
Okay, thank you for the introduction. My name is Bakhit Bishtawi, Dubai Health Authority. Today we will talk a bit about Google Scholar as the academic profile for all of you and all authors worldwide. Google Scholar actually will enhance your academic visibility after you create your profile. I am sure many of you might already create a profile, or the profile is there. By Google Scholar, you can track your citations and connect with peers in your field. What's Google Scholar? Simply, it's a free academic search engine. I am sure every one of you aware of that. And access it from anywhere. You can search for literature, scholarly literature, in a lot different disciplines and topics, and it's, as you know, free. Google Scholar as well is a citation metrics. You can track the impact of publications through comprehensive citation data. And also the most important part is Google Scholar support the author profiles by creating a personalized academic portfolio showcasing your research output. To create your profile, actually, you can access the profile setup by visiting google.com, but to start with scholar.google.com, and you will find at the top my profile. But before that, always, if you want to create your academic profile with Google Scholar, you need Gmail account. This is actually a must, and you need to log in to your Gmail account, then Chrome, Google, and you are there. So this is a must to start your profile with Google Scholar. Actually, some of your personal information will be pulled automatically from your Gmail, but still you can verify, you can change, you can modify your personal information, your institution affiliation, and even more. To make your profile searchable in the areas you are interested in, you can select the keywords that can represent your interests and your expertise. As well, at the end, you need to complete your profile by configuring the visibility settings, and you can even upload some of your professional headshots and even your picture, for example. You can manage, actually, the most important part in Google Scholar academic profile is you can manage your publications in one platform. And this is very important. If you have 1, 10, 20 papers, after time, you will maybe lose them, you will miss them, you don't know where are these papers. You may lose the citation, but with Google Scholar profile, you can add your publications there. You can import your work automatically, or even you can add them manually. The good thing is with Google profile, when you create your profile, the majority of your papers, your publications will be linked automatically to your profile. Maybe some of them you need to connect or integrate or add them manually. If there is any duplicates, you can merge such duplicates and maintain the accurate citation as well. You can remove sometimes any incorrect works for any reason. You can delete such wrongly attributed works to your profile. And another important part, you can set up an alert to receive notification whenever your paper, your publication, your research is cited by others. You can see who cited your papers after publication. You need actually to understand the Google Scholar metrics, and later on, when you have your academic profile, you will see such a graph there. And for example, the H index. The H index is the ranking for authors. The opposite is the impact factor, the ranking for journals. For, so for authors, we have the H index, number of papers, H, with at least H citations. And the significance is a balance between productivity and impact of your publications. Usually, H index used in academic institutions, universities, and you can show your index whenever somebody asks about that. A new H index is introduced. The I-10 index is the most top 10 citation for the publication, and it measures substantial of your work. And you will see also the total citations of all your work and research impact. As well, you can see the citation per year, and as well the research impact trends. All always be there in your profile, and you can send, share whenever you need that. Now, so as you will have a higher H index, you should work in your profile and optimize and increase the visibility of your profile by, for example, share your profile link among your colleagues. You can put this share link on your, for example, email, or maybe if you have a social network accounts, you can add it to your social platforms. You can use it everywhere. Also, when you create your profile, try to make it public so as to ensure that your work is discoverable by all. Because there is an option there, you can make your profile private. Also, better to add searchable keywords and include all the terms that you thought this might people search for. And another important part is to link, to connect to external profiles, like, for example, Orchid, or maybe your institutional pages. And also to maintain your name uniformed across publications. As you know, sometimes you use first name, last name. Sometimes you use first name, middle name, last name. Sometimes you use abbreviation or initial of your names. So try to use a consistent name format. All such things will increase the visibility, increase citation. That means increase the H index. For best practices for profile management, you need to, from time to time, maintain a current publication list. Simply, you need to keep regular updates to your profile. Also, try to claim the publications not there by adding a new work promptly for accurate metrics. Sometimes maybe the paper is published, but it takes time to reach your profile. Sometimes there you might find some errors for any reason, so you need to fix such errors. Some errors you can fix it by your own, or some you might send an email to Google Scholar for correction. And also you need to coordinate with co-authors, so as, for example, sometimes you are a co-author, but it's not, the paper is not shown under your academic profile. You might need to talk with the correspondence author or with other authors to ensure a consistent publication data across profiles. The conclusion is, you need to maximize your academic impact by monitor the metrics strategically, utilize citation data for academic advancement and research funding applications. This is important. And to establish research network by identifying and engaging with possible or potential research collaborators, and also try to implement regular maintenance in your academic profile by establishing a systematic schedule for profile updates to accurately represent current research output and to enhance your scholarly presence within the broader research community. It means optimizing your academic visibility. Now let's go and practice a little how to explore and build your academic profile. Actually, try to take this URL. This is the place where you can build your profile, or another way is to search in google.com that build Google Scholar academic profile, and for sure you will reach this link. I will click on this link, and I hope that you can see my screen still. Is it okay?
Yes.
Here I'm browsing the Google Scholar itself. Okay, and you can see here, set up your Google Scholar profile. Here the setup. Here is also the under setup. You can
We can
how
just so
yes, Dr.
we are still in your PowerPoint.
Okay. So I think I need to do
Maybe you need to share the screen
yes,
again.
yes. I think I need to skip the PowerPoint, maybe. Okay, I'll go back to share. Now here, share. Is it okay now?
Yes.
Yeah. The link I mentioned, okay, when you use it, or if you forget it, or for any reason, just search, normal search, build Google academic profile, these keywords, and you will come to this page where you can see an overview, and all the setup points are there. How do I create my profile? Some of my articles are not there, and etc. The citation, the public access, the updates, and even there is frequent asked questions. So this is the area where you can work with your academic profile. But remember always, you need to log in to your Gmail, or to make your account with Google active. For example, if you want to search for any colleague, any author, okay, just type the name, first name, last name, and write academic profile Google. Or if you want to find your academic profile, again, just type your name and search, and you will see, for example, the names there. And here we can see Fathia Al-Awadi. Okay, click on the, and here as you can see the academic profile of Fathia Al-Awadi as an author. You can see the years, okay, mashallah, and cited by, and this is what I mentioned, the graph. You can see at 2025, 174 citation so far. The H index for Fathia Al-Awadi, sorry, for authors, usually we are not mentioning the title. Okay, doctor, professor, we are not mentioning these things. So 22, and the IH is 38, and the total number of citations 1,506. Imagine if you want to remember such publications over the years, not easy for anyone to remember with citation even. Imagine if a university or a section or whoever ask you the list of your publication, not easy to find them. All what you should do is just to send them the link. Okay, the link, you will take it, Google Scholar will provide it for you. Just send one link for whoever, or maybe uh, just put this link in your CV, your resume, in your website if you have a website, anywhere, and that's all in one click. All your academic profile, all your citation is there. Okay, see this from 2018. You can follow nicely your ranking and all these things. I hope this quick session, will be beneficial for you. And as I mentioned, all what you need is a Google account, create the profile, take the URL, your profile link, and you can use it anywhere. If your affiliation is changed for any reason, you just go to your account and change your affiliation. And again, if you want to make all the details privately, you can use it from here, public access or not public access. From my side, I am done. Thank you very much. And if there is any question, I am ready for.
Thank you so much. Thank you so much, Dr. Bakhit. That was amazing. And thank you for sticking with time. Now I invite the three speakers for the Q&A session. To start with, I think there was a question for Dr. Ishma regarding the prednisolone. Up to how many days of prednisolone dosage for a quick management is all right in cases of IBD, inflammatory bowel disease?
Okay.
I think
Usually, see, for inflammatory bowel disease, we're giving steroids in times of acute flare, right? So, definitely you're dosing them for less than 1 month, right? For 2 to 3 weeks, and then you will taper it down and stop, right? Nowadays, we're not using long term steroids in these patients because we have other steroid sparing agents which are available, right? So if you're using steroids for less than 3 weeks or less than 3 to 4 weeks, you can just abruptly taper and stop the steroids as per guidelines, right?
so. No. I think there was also a comment from Dr. Majid Al-Amri, which I think is worth to highlight for the audience. I think in the presentation you mentioned about the cut of cortisol of, I think 450, if I'm not wrong. But these are used to be in the old assay. However, as recommended by the guidelines, the cortisol AM above 300 will be fine with the more accurate specific assay that have less cross-reactivity with the other steroid metabolites.
Yeah.
There is, yeah, this is just a comment, but I thought this comment is really valid.
I think it's
Uh,
quite valid.
yeah,
The only
and I
thing is
think
that,
you,
sorry. Yeah,
please,
doctor,
please.
please. No, the only thing is that, even if you have say, a steroid cutoff of 300 nanomoles per liter, again, we have to go clinically, right? Yani, suppose, even if your cortisol dynamic is above 300 nanomole per liter and safely you can stop your steroids, right? But again, I mean, at times, even with this, people in times of acute stress or illness, they might require an additional steroid dose, right? So, uh,
Yeah, this is absolutely right, Doctora. So this is the thresholds. It's meant to direct the physician whether to continue or discontinue steroid replacement, or they can safely discontinue. However, the instruction for the patient to take the sick day rules will continue, I think, up to 12 months post cessation of the steroid. So again, the education and the instruction, the steroid card will be continued using during the test, definitely.
yeah, yeah.
There is another question for you, Dr. Ferial, regarding the use of alpha blocker in patients who have BBGL, but they are normotensive.
For the patients who are PPGL and having non-mutensils, still there are studies and literature review shows that the use of alpha blockers is mandatory, because actually we are more concerned about the PPGL crisis or hypertensive crisis during the perioperative period. So it is the distribution of alpha receptors across the vessels, across the peripheral vessels and the central vessels, which help us to minimize the hemodynamic instability later. So there is role of alpha blockers. If we give alpha blockers even for 1 week before surgery, it decreases the mortality significantly by blocking the receptors.
Absolutely. So I think this is always debates that we attend, whether to block or not to block before BBGL, and there have been few studies and cohort around this. But this has to be interpreted cautiously, because most of these cohort coming from a highly specialized center where anesthesia and surgeons are very experienced. So if it is coming from this pool of institution, the conditions or the outcome will be great even without beta alpha blocker, which cannot be generalized to other places where these surgeries are done less often. Excellent.
Yes, I totally agree. Yeah.
Yeah. Mr. Dr. Bakhit, what is the major difference between Google Scholar and between ResearchGate? I'm not sure if
Between Google Scholar and
ResearchGate.
oh, big difference. Totally different, and what's let us say legitimate and could be rely on is Google Scholar.
Excellent. So,
We have Scopus also, but Scopus, as you know, um, it's with subscription for institution even, but the one available worldwide, easy, professional is Google Scholar.
amazing, amazing, excellent. Another question here is around how common are electrolyte abnormalities and hypoadrenalism, and what should be the treating doses of steroid to make adrenal gland recover. I think mainly they are asking about the electrolyte abnormalities and where we can find it, primary or tertiary and secondary. If Dr. Ishma, you can comment on this.
Um, Actually, we do have electrolyte abnormalities. If you have adrenal insufficiency, yes, and you do have hyperkalemia, hyponatremia, they are there. But frankly speaking, in tertiary and secondary adrenal insufficiency, we don't find a lot of abnormalities as compared to primary adrenal insufficiency. So I think it's just like, as we know, that symptomatically primary adrenal insufficiency is more symptomatic as compared to secondary and tertiary adrenal insufficiency, which can be insidious. And also similarly, the biochemical and electrolyte abnormalities usually we find more in primary adrenal insufficiency, right? And I think they had a second question about the steroid replacement dose.
I think the question was about treating doses of steroid to make the adrenal gland recover as early as possible. I
Yeah,
think,
this is yeah. So I think the same thing that definitely you need a shorter acting steroid. For example, hydrocortisone is preferable to a longer acting steroid because it is the shortest acting. And again, you have to start definitely when you come to when you're tapering your steroids. Again, when you're reaching the physiological dosage of steroids, for example, hydrocortisone between 15 to 25 milligram and prednisolone between 4 to 6 milligram. This is a time when you should start your taper very, very gradually now to allow for recovery of the hypothalamic pituitary axis. And again, here, you have to mimic the normal, or the natural circadian rhythm of steroids. You should dose your steroids in the morning time. If it's hydrocortisone and you divide it into 3 doses, then two-thirds of the dose should be given in the morning, and then the rest in the afternoon and evening. If it is prednisolone, then 2.5 or 5 milligram of prednisolone should be given in the morning only. The other thing is that because we know that the cortisol peaks in the morning, and then it will go down by 50%, and then it will plateau by the night. Similarly, we have an ACTH peak in the morning. So, if you give the steroids in the morning, there is another ACTH peak which will occur late, nocturnally, late night. So that ACTH peak will help you to stimulate the hypothalamic pituitary axis, right? So
Absolutely.
basically, yeah. So this is the whole thing that, and at the same time, you need to monitor for symptoms of adrenal insufficiency in these patients, right?
Exactly. So I think if you allow me to add, so if it is the hyperkalemia could be found when there is mineralocorticoid deficiency in a primary adrenal insufficiency. However, when it comes to secondary and tertiary, the mineralocorticoid will not be affected because it is under the RAS system. And therefore, you will have only, these patients are prone to hyponatremia, but hyperkalemia will not be seen in patients with the secondary or tertiary. And thanks, Doctora, for highlighting the recovery phases. So when we in the recovery phase from of the HPA axis, we have to interpret the ACTH and cortisol very cautiously because it depends on the recovery phase. We may see ACTH rising, but cortisol is still low. So people will start to think, we are diagnosing primary. No, it is the recovery of the HPA axis. So thank you for highlighting this. For Dr. Ferial, there is a question around the genetic test for BBGL. Is it done for every patient or what are there any specific indication?
Well, regarding the genetic testing, they are mainly indicated if the tumors are of bigger size, more than 5 centimeter, they are bilateral, and there is history of family for the same for the same familial syndromes. But in the paragangliomas, in comparison to FEWS, in the paragangliomas, in 60% of the cases, there is genetic predisposition. So we should be offered it to all, not only for the patient perspective, but for the family members as well. So paragangliomas who have more genetic predisposition rather than the pheochromocytomas. So ideally, it should be offered to all.
Okay, excellent. Another question for you, Doctora Isha. When tapering steroid in condition like polymyalgia, rheumatica, or vasculitis, do you rely on inflammatory marker or symptom controls? I'm not sure what they meant, but
I think
do you
for
have a comment?
polymyalgia, it's more of a symptom control rather than inflammatory markers, right? And again, I think it's some sort of a combined. Yani you need definitely symptomology first, and then also it should be backed up by your lab data, right? But usually for polymyalgia rheumatica, if it's primary polymyalgia rheumatica, we're not doing any inflammatory markers really. So it's mostly symptomology.
This reminds me actually of one. So some of these condition, vasculitis and rheumatological disease, when they start to taper them, they really face lots of difficulty. And Prof. Miran, who is in Imperial College, who is interested and fond of prednisolone, in their website there is a table where you can slowly, very slowly, taper prednisolone in difficult patients with vasculitis or rheumatological disease by almost 1 milligram every 7 weeks. And he actually took this from the rheumatology colleagues there, which is used in selected patients. So it can be used where we use very, very slow tapering in some patients. Another question, Ferial, is surgical resection always indicated once PBGL is confirmed, or there are exceptions when more observation is considered?
Well, keeping in view of the high mortality secondary to complications from hypertensive crisis, the definitive treatment is the surgical resection of it. But I did not come across any literature review where they document that it can be done medically observed, because even in the higher increased size, there is a risk of metastasis specifically for paragangliomas. So definitive treatment plan is to go for surgical resection and follow up.
Yeah. Again, this is mainly for adrenal and for secretory ones. For the non-secretory ones, it depends on several factors, including age, including underlying hereditary, including the location. And therefore, the involvement of the multidisciplinary team would be very important. Because, for example, you don't deal with all PPGL the same. Head and neck are quite different than the others, and so on. Excellent. I think we tried to cover most of the questions, and thank you, Dr. Ishma. I think you had answered many of the questions on the Q&A section. There is also just a comment that there would be a study which is running about the appropriate versus gradual stop of steroid. Hopefully, inshallah, once it is released in the future, I think Dr. Majid also highlighted for it. Maybe it be presented. Actually, you reminded just for a discussion. There was a recent paper, I think last year, from Sheffield, where they took retrospectively patients who were on steroid, and they compare whether they taper them from prednisolone immediately or they change them to hydrocortisone and then take them off. And there was no difference, because I'm not sure what you are doing, Ferial and Ishma, in your institution. Some institution, they will change the patient from prednisolone to hydrocortisone. Others will just wean the patient from prednisolone directly.
Actually, frankly speaking, doctor, at times we're weaning them from prednisolone directly, right? But some certain difficult patients, we will switch to hydrocortisone, right?
Okay,
This is
so you select based on patients.
Yeah, but usually the vast majority of patients were tapering prednisolone directly, right?
I agree
Excellent.
with Dr. Ishma. It depends on the patient and the patient financial issues and the compliance to the medication as well. If patient is highly non-compliant and there is increased risk of adrenal insufficiency, we prefer to keep them on long-acting like prednisolone. But it is advisable to check before the short-acting test or the cortisol AM that patient should be on the physiological dose of either of the steroid or on the shortest acting like hydrocortisone. For example, if patient is hydrocortisone, we ask them to skip the evening dose and to keep the morning dose in the pocket, do the cortisol and take it right after that. So it depends on the patient's baseline characteristics and financial as well as the compliance issues.
Excellent. Thank you so much for all of you. Thank you, Dr. Ishma. Thank you, Dr. Faryal.
very
Thank you,
much.
Dr. Bakhit. It was very interesting talks and discussion. And hopefully we see you in future meetings as well. Thank you so much.
Thank you very much,
Sure.
Dr.
Thank you so much, Dr. Aya. Thank you.
Now we are moving to the industry sponsor talk by our sponsor for this event, Servier, and it will be around the glycoside. And the speaker is Dr. Sara Al-Ghandour, who is a consultant and endocrinologist at Mediclinic, Parkview Hospital in Dubai. Dr. Sara is also adjunct clinical assistant professor at Mohammed bin Rashid University of Medicine and Health Science in Dubai. Dr. Sara, welcome, and the floor is yours.
Thank you very much, and thank you for all the speakers today for this excellent presentation. I learned a lot personally. So now we're switching gears. I'll be discussing the efficacy and the safety of glycoside in the real-world setting. I have no disclosure. And to start with, we all have to acknowledge the importance of early glycemic control in patients with type 2 diabetes. Unfortunately, in the GCC area, we can see that we're reaching suboptimal control. Only 17% of patients are actually reaching the target HbA1c of below 7%, and the rest have an HbA1c above that. If we look specifically in the UAE region, we can see that this is very representative of the whole Arab country, where the majority of the patients are not reaching their HbA1c target, unfortunately. Almost half have an HbA1c above 8%. Now, why this is important? Because as we know that the HbA1c control is very strongly correlated with the onset and the progression of micro and macrovascular complications. As you can see in those two graphs, the rate of onset of acute myocardial infarction is very closely related to the HbA1c of the patient, his systolic blood pressure, and the LDL cholesterol. So those three main factors are the predictor and the most important predictor of the onset of acute myocardial infarction in patients with or without pre-existing conditions. And historically, we know that the UKPDS trial showed us that the HbA1c control is of utmost importance. Every 1% reduction of HbA1c will reduce the rate of onset and the progression of diabetes-related complication. You can see that a 21% reduction of all diabetes-related complication can be achieved with every 1% decrease in HbA1c. All-cause mortality can be reduced by 14%, fatal and non-fatal myocardial infarction. And it is important to note that almost half of the risk of lower extremity amputation can be reduced with a reduction of HbA1c by 1%. Now let's move to look at the effect of gliclazide when we compare it to other standard of care, here specifically the sitagliptin in the real world. So this real world data trial aim was to compare the efficacy and the safety of gliclazide in patients with type 2 diabetes to achieve primarily an HbA1c below 7%. And as secondary outcome, we looked at the time to achieve an HbA1c below 6.5% and the treatment durability and the persistence of the good control, diabetes control in this patient. And very important secondary outcome was the frequency of hypoglycemic events. So let's go over the study design. After a baseline period, new users of gliclazide or sitagliptin, the DPP-4 inhibitors, were enrolled and they were followed over 9 years for observation. The main observation point were the HbA1c assessment, the durability and the persistence of the diabetes control, and the hypoglycemic events. Patients were adult, above 18 years of age, had metformin as their baseline treatment, and they had the HbA1c above 7% prior to their enrollment. They excluded type 1 diabetic, a patient with gestational diabetes, and secondary diabetes. In terms of baseline characteristics, patients in both groups were comparable in terms of gender. Their mean age was around 63 years. The mean HbA1c in both groups was comparable, 8.5 and 8.6%. The BMI was around 30, and the mean duration of diabetes of 4.4 years. In terms of baseline medication, they were also comparable in terms of their anticoagulant therapy, antihypertensive, antiplatelet, and lipid-lowering therapy. Now, moving to discuss the results, we can see that there is a rapid separation of the curves favoring gliclazide, and the improvement of the HbA1c can be noticed as early as 3 months after starting the observation trial. Patients in the gliclazide group were 35% more likely to achieve an HbA1c target of below 7%. Moving to the secondary outcome, looking at an HbA1c below 6.5%, the results are more significant, and we can see an even rapid and more prominent separation of curves favoring gliclazide compared to the sitagliptin. And patients in the gliclazide group had a 51% chance of achieving the HbA1c target of below 6.5% compared to the sitagliptin group. In terms of durability and persistence, we can see that both curves are superimposed, meaning that both treatments are durable and the persistence of diabetes control was not different between both groups of sitagliptin and gliclazide. And most importantly, looking at the hypoglycemic event in the sulfonylurea arm, we can see that the total number of hypoglycemic event was numerically low and not very different in both groups. The rate of severe hypoglycemic event was almost negligible, with 4 in 3,000 patient years recorded to have hypoglycemia in the gliclazide. So in summary, what did we learn from this real-world study? This study showed us, highlighted the safety of sulfonylurea. It also showed us that gliclazide had a more effective glucose-lowering effect compared to sitagliptin, with a very negligible and low rate of hypoglycemia and high durability and persistence to treatment. Now moving to another real-world data, the DIA Ramadan study, and we'll be looking at a subgroup in this study. So just to give you some background, the DIA Ramadan study is a real-world observational non-comparative study that showed that patients with type 2 diabetes receiving gliclazide during Ramadan, they were able to control and maintain their glycemic targets with no severe hypoglycemic events. And the main aim of this sub-analysis is to examine whether the positive results observed in the DIA Ramadan were also relevant to the GCC region. Looking at the study population, the Middle East population constituted 354 patients from the global population, around 30%. And then the key inclusion criteria were mostly adult, treated with gliclazide for at least 90 days before the start of the fast. And they were also followed during the Ramadan fast with an ability to monitor their blood glucose during the fast. And they will be willing to fast and did not require insulin. They were also followed post-Ramadan for 4 to 6 weeks. Comparing the subgroup of GCC, including KSA, UAE, and Kuwait, we can see that compared to the global population, the group was comparable in terms of age. They had a slightly higher BMI, a slightly higher HbA1c of 7.9%. The mean dose of gliclazide was higher in the GCC countries compared to the global population. And most of the patients, almost half of them, were on double dose, 2 tablets or 120 milligram of gliclazide. Also important to note that a significantly higher percentage of patients had established cardiovascular disease, and almost half, 52%, if we add these two categories, were shown to have very high or high risk of IDF-DAR risk category. The most important highlight of the sub-analysis trial is that the hypoglycemic event were very low in the GCC group compared to the global population, and the confirmed hypoglycemic event were almost negligible. So this study showed us that the use of gliclazide was safe and had low risk of hypoglycemia. In addition, it did also show us that patients who fasted Ramadan did show a reduction in their HbA1c by approximately 0.3% and a reduction in their body weight by 0.7 kgs after the end of the fast. So in summary, what did we learn from this sub-analysis? The rate of symptomatic hypoglycemia was seen to be low. The confirmed hypoglycemia was almost negligible, and almost none of the patients had a severe hypoglycemic attack. Patients who received gliclazide could reduce their A1C by 0.3% and their body weight by 0.7 kgs at the end of the fast. So as a conclusion, again, the low rate of symptomatic hypoglycemia were confirmed in this sub-analysis of the DIA Ramadan, no severe hypoglycemia, and maintenance of good glycemic control and body weight. Now, what about the cardiovascular safety of gliclazide? Compared to other sulfonylurea, this meta-analysis and the systematic review shows us that gliclazide had the lowest risk of cardiovascular mortality. So it actually favored this all-cause mortality curve favored the use of gliclazide compared to the other sulfonylurea. And similarly, the safest sulfonylurea, which showed the lowest cardiovascular mortality, was also scored to be the gliclazide compared to the other in the group. In terms of renal safety, the ADVANCE-ON trial provide us with 10 years of evidence that gliclazide was beneficial in reducing the risk of albuminuria improvement in the new onset macroalbuminuria by around 30%, and most importantly, a reduction in the progression to end-stage renal disease by 65%. So in conclusion, today we'll be able to take home as message that unfortunately our diabetes control in this part of the world is still suboptimal, and there is a lot of work for us to do. Early control is very important to reduce the progression of micro and macrovascular complications. Glycemic control is very important, and we will have to choose our medication in terms of the efficacy and their safety and durability. And we did talk extensively about the gliclazide, its efficacy and safety, its low risk of hypoglycemia, and the durability of its treatments. And with this, I'll be ending my talk. I'll be happy to answer any questions.
Thank you so much, Dr. Sarah. That was amazing. Someone is asking about the cardiovascular outcome with the gliclazide.
So in terms of cardiovascular safety, we could show that the medication is showed definitely safety compared to other sulfonylurea. I showed the meta-analysis showing that it is favored compared to other sulfonylurea in the group. So in terms of safety, we could rest assured that there is definitely no increased concern and a lower rate of hypoglycemia compared to other alternatives.
However, did you think this safety and cardiovascular safety is due to less risk of hypoglycemia?
I think it's one of the important, I mean, from the UK PDS and the historical trial showing the intensive control with the standard of care with intensive sulfonylurea that used to be used previously, the highest concern of cardiovascular safety was mostly the hypoglycemia. So one of the misconception that were around the use of sulfonylurea as the increased risk of hypoglycemia with gliclazide in particular, that was the lowest concern.
I think there is another two questions. I will just merge them. So in general, the question is which patient that you would not use gliclazide, will avoid gliclazide for, and which profile of patient, and when you will choose gliclazide over SGLT2 inhibitor or DDP4.
Yes, we definitely have to acknowledge the use and the importance in our armamentarium of, I mean, diabetes medication. We definitely have medication that with cardiovascular benefit rather than cardiovascular safety. We have to prioritize the use of medication in patients with either established cardiovascular disease or high risk of cardiovascular disease to reduce that progression. And mainly this is talking about GLP-1 agonist and the SGLT2 inhibitor. We would want to think about optimizing the control just in case patients were already on this optimal therapy and we want to maybe delay the use of insulin. So gliclazide will provide a reduction in the HbA1c of approximately 1% with a good safety profile. So this is one of the medication to be maybe added to the regimen to optimize the control. Another category of patients are patients with low income, difficult to get the high expensive medication, patient with safety concern and contraindication for the use of GLP-1 and SGLT2 inhibitor. And I think we're facing an increasing number with patients not tolerating and so on.
Excellent. Doctor, I think there are still a few questions. I'm not sure if you would like to answer them live or on the chat. One of them, I just will select one about the use of gliclazide in end-stage renal disease or in patient with liver transplant.
Yeah, I would, I mean, in terms of the gliclazide use, especially in patients with end-stage renal disease, we would need to acknowledge that those patients had a lower requirement for anti-diabetic medication in general. So we need to be cautious about the use, definitely reduce and minimize the dose and monitor the blood sugar regularly. I mean, in terms of liver transplant, I wouldn't. I wouldn't see any contraindication for the use of sulfonylurea. Definitely, the risk of hypoglycemia compared to patients without these condition is higher, so it should be used in cautious and with caution.
Absolutely. I think it's all should be on the oriented or based on your patient profile and their insurance profile as well. For example, all the new medication with the cardioprotective outcome,
Absolutely.
unfortunately expensive. Many, for example, patient here in Abu Dhabi with Daman patient cannot afford it. So if we select from sulfonylurea, glycoside, at least the safest one in terms of cardiovascular safety. So I think one of the questions you already answered, differentiating between cardiovascular outcome and safety. We are discussing here safety, not cardiovascular outcome. Thank you, Dr. Sarah. It was a pleasure having you. And thank you for staying with us and answering all these questions. Thank you so much.
Thank you. It was my pleasure.
Thank you for all the attendees who are still with us. Inshallah, hopefully you will receive your CME hours after 2 weeks from the webinar. If you would like to review the webinar, it will be available on demand on the EDS institution website as well as EDS YouTube channel. Also, if you would like to have an idea about the upcoming webinars, and it will be on the EDS website. The next Young Leader Forum hopefully will be next September, and you will hear soon about that. Also, we would like you to mark your calendar for the upcoming our major endocrine congress, which is the 16th Emirates Diabetes Endocrine Congress. Next year will happen between 6 and 8 February 2026. So please mark calendar and book your leave from now. Thank you again for all the attendees, and thanks for the support of Servier for their continuous support of this educational activity. Thank you so much.